We're from Southeastern Spine Center and Research Institute, and when I say we, my partner Tan Lee, which some of you in the audience know, is also a fellowship-trained spine surgeon, and we practice upstairs. We're on the second floor of this building. We have two other part-time doctors, Dr. David Karp and Dr. David Scott. Upstairs, we also have our clinical research offices. We do some clinical studies. We participated in the clearance of some new products, which I'll show you tonight. This is one, it's called a CoFlex. This is a device that will be able to, and does, prevent people from having a fusion. So some people who need to have a 1 or 2 level fusion now can proceed forward and have a motion sparing device like that CoFlex. I'll show you a little video later on, and that allows continuation of motion, so it has several advantages over fusion. We've been the primary investigation site, a primary investigator for several new products. So for example, the CoFlex, and for a disc replacement that's placed through a tube to the side, that is not available yet. We were one of 20 sites, or are one of 20 sites in the US where these things are being done. So right now, actually, through our practice is the only place in this area, Sarasota, Bradenton, Port Charlotte, down in Naples area, where you can have a CoFlex device placed. It was just cleared by the FDA last fall. Important things that we talk to our patients about, which are part of the program, include a proper diet, regular exercise, following up with therapy at home. I have many patients who don't really maximize their benefits from therapy because they go to therapy, but then when they go home, they don't really follow through with it. And therapists always give you some homework. They give you some things that you can do to follow through. And I tell my patients, once you go to therapy for your spine, for strengthening and balance training, this is something that you should keep up on a regular basis for the rest of your life. Oftentimes people go to the gym and they focus on certain groups, they strengthen their legs, they forget about their calves, they strengthen their chest, they forget about their spine, and many bodybuilders really aren't well balanced, and they can have back problems just like everybody else. An analogy I like to use is that you could be a world-class tennis player or football player, but if I put you on my son's high school soccer team, you won't even touch the ball. It's because it's completely different. Sports training is specific for a sport, just like therapy is specific for a specific diagnosis. So if you have instability in your spine, I can't tell you how many times I have people come in with instability and they say, but I've been doing all of my stretches. Well, stretching in that situation for them may not be the best thing. They really need core strengthening, along with maintaining fully lengthened functional muscles. The pool, if you haven't seen it, is adjacent to this room. That's a wonderful place for a lot of reasons. You can see Keefe here, and I think Keefe used to be 6'4". He may be 6'3" now. I don't know. He's getting up there. And a shorter patient. And so the beautiful thing is that that pool can be adjusted very quickly for the patient's height, because we want to optimize buoyancy but still keep it a functional environment for people to exercise in 90-degree water. And then you're not seeing it right now, but they're standing on a treadmill. So there's also the opportunity to do treadmill to increase aerobic fitness activity, but also to strengthen the muscles. I sent a patient down here today who literally could only walk 25 feet. And one of the first things we'll do is get him into the pool and unweight his spine. And he's overweight. I talked to him about weight loss, and we'll get him try to work on his aerobic fitness while we also work on his spinal balance and strengthening. Minimally invasive surgery has been shown in studies to be better than open surgery because in many cases it can be performed outpatient, or for a bigger procedure like a fusion instrumentation, even just one night in the hospital and home the next day is very common. There's less pain, the less need for narcotic pain medications, and that means, of course, less problems with narcotics like constipation and drowsiness and the risk of falling. And so people get back to activities much faster. And so these things can be applied to a variety of problems. Who's not heard of spinal stenosis? Anybody not hear of that term? So that's very common. Probably the most common diagnosis we treat. Disc herniations also are treated that way. Chemical disc irritation. So some people will have no disc herniation, but they'll have a tear in their disc. And it may have come, for example, from a traumatic injury. And so for a period of time, you can get irritation of a nerve so that you have pain down your leg, just like a disc herniation. But you get the MRI and there's no disc herniation, but you don't understand it because there's pain. It's because the chemical is irritating the nerve just like pressure would irritate the nerve. And so this is one of those examples where an epidural steroid injection may really fix the problem. So it's important to watch out for those subtle things. And then a whole other category is instability, and that means the bones are shifting inappropriately and or the spine is out of alignment, so you have a curve or a scoliosis, and in many cases that can tend to be a progressive thing. The unfortunate thing is, and this is the bad news if you don't know it already, by the time we reach 80, most of us are going to lose about 2 inches in height. And a lot of that comes from the disc. We have so many discs in our spine that you can imagine that if every one of these discs, which is in between these bones, lost 1/16 of an inch, that adds up pretty quickly. And what happens on top of that is these bones in the mid-thoracic spine tend to become wedge-shaped over time because of osteoporosis, which everybody gets. Men and women get age-related osteoporosis. Women also have postmenopausal, so we tend to lean forward. And unfortunately, the more you lean forward, the more you lean forward. It becomes a progressive problem. Things that you can do to help fight that, of course, are exercise, extension exercises, good diet, making sure you know if you have osteoporosis and making sure it's treated well. We touched on this before, but I cringe because unfortunately a lot of people are undergoing pain management, but it's really pain maintenance. If you're taking narcotics, then you're covering things up and you're not treating the problem, and it's not a good road to go down. And that's an acute problem that we're all aware of here in Florida, especially, I think. About 8 people a day die in Florida of overdose of prescription pain medication. It's a horrible problem, yeah. So in our practice, you're usually at the point where you've had severe pain, weakness, numbness, inability to walk, or it's been more than 6 weeks, so you come. The diagnosis includes a detailed interview of what's been going on with you, a physical examination, X-rays, which we do right on site, and oftentimes an MRI. In fact, many people will come to us having had some of these things done already. So we put these together, we design a treatment plan, we plan to correct the problem with physical therapy or bracing, and then pain management or injections, whatever may be necessary. And then only if people fail that do we go towards a minimally invasive procedure to fix it. I think we touched on all of this. The value of minimally invasive surgery is that it's often a 23-hour or less hospital stay. There's less pain, there's less blood loss associated, less infection, faster return to activities, and it's more cosmetic because of small incisions. Over here is a series of dilating tubes. These are like those Russian dolls that are stacked. Does anybody know what they're called? Nesting. They're nesting. These are nesting tubes, and they start very, very small. So we start with the smallest one, and then we go bigger, 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 bigger. And the reason you do that is because you're gently dilating the muscle. So all around that tube, there's very little force on the muscle itself. And when you take the tubes out, the muscles go like this, they go back together again. So there's very little damage, very much less trauma than you can imagine if you make an incision this big and strip the muscles off the spine and use retractors. A retractor holds the muscle back and prevents blood flow. So if the operation takes more than an hour, it's like a tourniquet being on for more than an hour. It gets no blood flow, so the muscle tends to die. That's why you end up with scar tissue. And when people say failed back syndrome, what that really means is the retractors that were used, the techniques that were used resulted in so much muscle death that there's now scar tissue and you don't have functional muscle in the back. And so what happens with that is we lose our spinal balance, right? C7 in the neck should be right over the front part of the sacrum. This is a nice gentle curve, and when we do scoliosis surgery in adults and children, we talk about this. It's all about sagittal balance. That you need to remain upright, because if we lose some of that sagittal balance and we start to move forward, the more you move forward, the more you move forward. And then you have more stress on the facet joints and more stress on the muscles, and you reach some point where the muscles can't maintain an upright posture, and then you end up turning over like this. And so that damage to these muscles and the failed back syndrome often result in people with a positive sagittal balance. In other words, their head is thrust forward because of the loss of the normal lordosis in the lumbar spine. This can be normal as up to 60 degrees or so. And so what happens then is the neck comes up like this because you need to be able to see. So I'm not going to walk around like this. I'm going to hold my neck up, and so then that leads to neck problems. So it's like a domino effect. So on the right-hand side, you see one of these tubes in place through which a decompression can be done, which means you may have heard the word laminectomy, taking off bone spurs, discectomy. And so I'll show you, this is not a video, but I'll run through a series of pictures so that you'll see how this works. This is a fluoroscopic image. This is an image that we use with something called a C-arm that's mobile, and we use it in the operating room to be sure we're operating exactly where we need to be. This is the tailbone. The belly's here, the back is here. These are the vertebral bodies. That's L5, that's L4, that's L3. So that's the L3, L4 disc space. And this little dark line coming in from the right-hand side is the first tube. And so then we go bigger, 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 and then I took out all the tubes on the inside, so now that's hollow. So now we have a nice little access, 2-centimeter incision. We can work very deep within the spine. Those tubes come anywhere from 4 centimeters to that big. And so if people, it doesn't matter what size the patient is. In fact, it's easier to fix somebody to work on their spine if they're a big person through a tube than it is to do an open procedure. And the reason is the deeper down you have to go, the bigger incision it has to be in order to be able to get in there. So, so that's very helpful. To me, makes the cases go faster, and it's much less traumatic on the patients. And that's an example of that CoFlex device. You see it squeezing and bending? So by putting that spacer in, we open up, take the pressure off the nerves, and stabilize it. So it's interesting because in the study that we participated in, it was found that people who had a slip vertebrae, had back pain and leg pain, did better, had even better results than people who didn't have a slip vertebrae. Who would have thought? You would think a slip vertebrae is a worse condition, so why would people do better than people who don't have it? I don't know. Everybody did well with the CoFlex device. It was shown to be superior to fusion for treatment of certain problems, but people who had instability in their spine actually did better. So the question is, if you have a pinched nerve and you have weakness, how soon should that problem be addressed? Well, you should get a diagnosis right away. And oftentimes the treatment for that is physical therapy. I had a gentleman I saw today, I can tell you about him without using his name. He had a pinched nerve and he had biceps weakness. He's a Brazilian Jiu-Jitsu guy. He's been doing it for 7 years, and he got to the point where he couldn't compete anymore, and he has biceps weakness. And he had seen someone else who wanted to do a fusion on his neck, and he hadn't had x-rays, so I got x-rays of his neck. He didn't have any instability, and I said, physical therapy. You've got an excellent chance of this getting better with cervical traction and the right kind of physical therapy. So even though he has weakness, he needs to be treated. I mean, especially because he has weakness, he needs to be treated. And in this case, hopefully the treatment will be physical therapy. If not, then we'll do a fusion and instrumentation on him. So another way to ask that question is, how long can weakness go before I have permanent loss of muscle function? And that's very variable. It depends on what's causing the weakness. If it's a big disc herniation or severe stenosis. Weakness from stenosis, people can go longer because it comes on gradually, so it's harder to get permanent nerve injury. The nerve accommodates a little bit. But if you have a big disc herniation pinching a nerve, generally you want to fix those within the first month or 2. If it goes somewhere between 6 and 12 months and you have an operation after that, the chances of getting completely better start to drop down. I had one gentleman who was a bodybuilder, and he had waited a year because he just didn't want spine surgery. He had so much weakness that he lost his entire triceps, and he was still having pain. So we did the operation at C6, C7, and his pain went away, but his muscle will never come back because there's been permanent injury to the nerve. Healthy muscles need healthy nerve input. So even when you're resting, the nerves are sending little impulses to keep your muscles healthy and big. And if you don't get that, they start to wither away and go away. If you have a fusion, it's very important to maintain your spinal strength and mobility, because if you don't, then you will start developing a problem at an adjacent level. And we know that if someone has a fusion, if even under the best of circumstances, in about 10 years you will have about a 3 out of 10 chance of having more trouble with your back. If you look at large numbers of studies, that's just the way it is, even under the best of circumstances. Now, that doesn't mean you're going to need another fusion, and it doesn't mean that that one fusion falls apart. Usually when you have a fusion, you'll never have any trouble with that part of your back again. But that, if you think about it, that motion segment's gone, so all the force that's on the body now is distributed along other segments, and so you have more force there, so you're more likely to have wear and tear on those other discs than if you had an open operation and you've had muscle death and you lose some of your normal alignment. You're going to have even more bad forces on those discs and be more likely to have the problem. Another way to look at it, though, is if you're having pain that's keeping you from enjoying life on a daily basis, and you have a fusion, you have a 7 out of 10 chance of never having trouble with your back again.